It's my pleasure to introduce Dr. Rachel Epstein. Rachel is an assistant professor at Boston University and School of Medicine there. She's an internal medicine and pediatrics provider by training. Rachel, over to you. Thank you so much.
Great. Thank you, Dr. Gupta, and thank you to the coalition and all the organizers for having me here today. And hopefully the slides come up okay. Let me know if they do not. There we go. And so I'll be talking about improving linkage to hepatitis C care for pregnant and postpartum women. No conflicts of interest to disclose, and this is funding for prior and current projects I'll be discussing. I will delve very briefly into the background, as Dr. Gupta has already set this up, as well as the excellent November webinar, and then discuss some programmatic interventions to improve linkage to care and treatment, as well as some work to try to eliminate some of the barriers to treatment mentioned in that previous slide, especially some of the insurance aspects. So as you well know, the prevalence of both opioid use disorder and hepatitis C have, and I'm going to just make sure everything's out of the way here, have increased significantly over the past 2 decades. As you can see on the left for opioid use disorder, on the right for hepatitis C, the prevalence has risen more than 5-fold for both from 1999 or 2000 to 2015 to 17 for each. And this is among pregnant women, so based on the national inpatient sample. Sorry, just trying to advance. There we go. And this slide just collects some of the recent data. There's much more about linkage to care and treatment in reproductive age women. And what it displays here, the first line is data that we're analyzing now in Trinetics, which is a national electronic medical health record database. The second line is Modern, which Dr. Kranz presented on the last webinar, Medicaid data from 6 states across the country. The latter two are studies of individual obstetrics clinics in the southern US, so the University of Alabama and the University of South Carolina. And what you'll notice is for all of these women with hepatitis C virus, less than 50% have linked to care, and only 2 to 10% have been treated. There are different time periods, slightly different criteria in each study, but the overall message is clear that we need to do better in both linkage to care and especially treatment. And so what are some programmatic interventions to improve linkage and treatment rates? At Boston Medical Center, the institution where I work, there has been a number of different programs implemented. There have been programs implemented over the last few years. And all of this is in the setting of programs that have already been implemented. So the Respect Clinic is an excellent prenatal clinic for women with substance use, and there are a number of other wraparound services for addiction medicine throughout the clinic, which I think are key aspects and not unique to BMC, but important aspects to HCV care in general. And so the Respect Clinic is a prenatal clinic for women with substance use, and it is multidisciplinary. And so the obstetricians and family med physicians prescribe medications for opioid use disorder right in the clinic. There's addiction psychiatry, social work, peer recovery coaches, a nurse manager, and a number of other specialties such as child life to try to address some of the major barriers that women face during pregnancy and postpartum period. Anything from stigma to shame, fears of criminalization, finding time for childcare and having to weigh that with getting treated, transportation issues. They'll help to arrange transportation to the clinic. And I think two of the big things that I'll point on here are that there are few OBs who have substance use disorder or hepatitis C virus training, and that was also pointed out in Dr. Gupta's slide there. And then difficulty linking to primary care physicians or other specialists postpartum. And so in order to address some of these continued barriers, there are a number of programs that we implemented at BMC. So first, in October of 2016, we started a pediatric infectious diseases consult at delivery in the hospital to link both moms and infants to hepatitis C care. And that was taking women who were either seen in that Respect prenatal clinic or just delivered at Boston Medical Center and trying to link them up with infectious diseases, with office-based addiction treatment in either internal medicine or family medicine at BMC or wherever they wanted to seek care. And for those younger moms in the Catalyst Clinic, addiction medicine clinic for adolescents. So taking from an inpatient consult and linking them to various other clinics where there's HCV treatment occurring. The Respect team then took it one step further and created the SOFAR clinic, really through the pediatrics department at BMC. And in July of 2017, they started the Supporting Our Families Through Addiction and Recovery, which is a co-located postpartum and pediatric care clinic for women with substance use and their infants, so that women weren't choosing between their own appointment and their infant's care. And the idea is that everything could be under one roof. They have fewer appointments, fewer places to go, and it could help increase follow-up for both babies and moms. And so what did this look like in practice? For all women who were identified as HCV seropositive during pregnancy, they would receive a hepatitis C virus consult during delivery hospitalization, and then appointment coordination to help make these appointments at other sites, and contact during those visits, particularly for women who were involved in the SOFAR clinic. And this was, the idea of this was to help with both infant and mom's care. We studied the effects of this clinic in an article recently published in Hepatology Communications. We looked at the hepatitis C consult, and we compared 3 different groups. So in orange is pre-intervention, so before 2016. Blue is the hepatitis C consult, and green is the consult as well as the SOFAR clinic, so women who were able to be involved in both. And the consult increased the odds of starting treatment 2.4 times, and the consult and SOFAR together about almost 3.5 times the odds of starting treatment compared to women delivering pre-intervention. And so that's looking specifically at this bar. When we say link to care, we say that they actually had medication ordered and that they likely started treatment, which we later confirmed with chart review. And so granted, this is a retrospective study. It is of a program implementation. It's not a randomized controlled trial, but we did follow women up through 2019, including those who delivered in 2014, and only compared to women who had continued care through BMC. So it does seem to have had some impact, but you'll see even at most 50% of these women are starting treatment, which is a lot better than 2.5%, but it's still, there's still room to go. And so the next intervention that began was in 2021, the HCV treatment task force, which is HCV treatment by OBs and pharmacists within postpartum care. And this looks like within the postpartum year of follow-up, after initial postpartum care, really staging Hep C, treating Hep C, and doing SVR checks right in OB clinic. The pharmacist is a huge part of the figuring out the prior authorization, the medication details, making sure all the right labs are ordered, and really helping with adherence support, even delivering the medications to them, and has been an amazing support through this program. Very early data indicate that there were 46 patients eligible over the first 2 years of the program, 21 of them successfully engaged in treatment and engaged in care, and 11 have started treatment, most of whom have finished by now. There are another 10 who are either still pregnant, breastfeeding, or completing their lab work, but are interested in treatment as well. So still not perfect, but significantly improving from some of the prior data. And the infrastructure of this has people being treated in the OB clinic, so under the same roof by obstetricians, which I'll get back to. And so just to finish out, some work to eliminate barriers to treatment. So insurance restrictions are still a huge issue in the United States. Every country has its own policies as well, but there are still 31 state Medicaid programs that require prior authorizations. There are still a few that require abstinence or advanced liver disease, and 12 that require treatment by or in consultation with a specialist. These numbers are much better than they were a few years ago, but we still have more work to make sure that everyone can actually get treated no matter where they live in the US. And as I said, many other countries abroad are doing a much better job of this. There's still specific laboratory testing that's also required for most prior authorizations, and then commercial insurers have very similar restrictions that are less transparent. And so what can we do to remove these insurance barriers? The National Viral Hepatitis Roundtable and the Center for Health Law and Policy Innovation at Harvard Law School have done a wonderful job of categorizing what these restrictions are and really working on advocacy to bring down these barriers. Another step that we can do is economic studies to show that these restrictions are not cost effective and that they obstruct progress towards elimination. This is a study I'll just touch briefly, where we actually saw that there is some spillover from the Medicaid restrictions to commercial insurance. So this graph actually shows that blue line are commercially insured patients' hepatitis C screening in states that had loosened their Medicaid restrictions. So there's spillover even to commercially insured patients. So important to deconstruct both barriers. And we also looked at what are the testing requirements for prior authorizations. And through funding from the Donahue Foundation that we presented at the Liver meeting last year, we demonstrated better clinical outcomes using in-office methods. So calculating a FIB4 or an APRI from labs that are already done, as opposed to sending people to a lab or requiring imaging at a referral center. And the primary driver of this was loss to follow-up from not finishing testing. And so the next steps from this work are to really work on increasing transparency and working to eliminate requirements. In light of time, I won't get further into this, but it's also really important that people are covered by insurance. And the Kaiser Family Foundation has done some great work to show which states actually have 12-month extensions so that postpartum women can continue to have insurance coverage beyond the public health emergency. And the last thing I'll touch on is just that treatment during pregnancy really has the power to do even more. This is a cost effectiveness study that shows that in the first 5 and 10 years after pregnancy, treatment during pregnancy will result in more people treated than if we wait till afterwards, and all of the barriers that go with loss to care as we link and treat people. And so in summary, co-location of care, so everything under the same roof, is a key factor. Having a multidisciplinary team where we have social work and pharmacy and team meetings to coordinate care, and as well reducing insurance barriers, increasing transparency, removing prior authorizations, and working on the different steps to treat during pregnancy, which I think one of the most important steps, as Dr. Gupta mentioned, is really that we have obstetricians and we have primary care who are feeling comfortable treating Hep C during pregnancy. And I think putting that into place, whether it's postpartum now and in pregnancy later, could be a huge thing if tomorrow or in 1 year, we have a safety data and recommendations to treat during pregnancy more universally. Just like to acknowledge co-authors and importantly, all the clinicians that make this happen. Thank you.